Okay.
Hello, everybody. Thanks for joining us. We have the Northeast Indiana team with us today. We have Shelly Rigsby-Treese, who is the program leader for the Northeast Indiana team. And she is here to talk about her engagement with hospital physicians as well as primary care physicians and how that has significantly improved their care transitions program. And so first we want to showcase their data scorecard, and you can see that as a result of their excellent partnerships with both hospitals and physicians, they've been able to achieve in the spring of 2015 a target enrollment of 127.7% and a target footprint of 24%. So clearly they've been doing a lot on their partnerships to be able to achieve these high marks. And so, Shelly, I want to go ahead and dive right in and ask a little bit about your partnerships with physicians. And I'm wondering if you could talk first a little bit about how you partner with physicians in the hospital and what you do to get them engaged with the Care Transitions program.
Sure. Well, what we noticed early on in one of our highest readmitting hospitals was we were having a higher number of refusal rates in the hospitals when the coach was going into the hospital rooms to talk with the patients. What we were able to do was talk with the champion and compare numbers and ask her assistance in what she thought we could do internally to help with this refusal rate. She had suggested that we meet with the head of hospitalists and the hospitalists to discuss our program and see what kind of partnership we might be able to establish with those hospitalists. So we were able to go to a meeting, present on Care Transitions program, show them the benefit and the value to their patients, and they had agreed then to, anytime there was a refusal, that the coach would call the champion and inform the hospital champion, and then that hospital champion would reach out to the hospitalist. In turn, that hospitalist would go into the room and talk with that patient and let them know that Care Transitions is a program that the hospital really supports, that the hospitalist supports this, and that it is part of their discharge plan. Within a month of doing this, we had excellent results. Our enrollments increased, and our refusal rate went down at that hospital. So some other strategies we started at some of the hospitals, of course, were to try to get all of the physicians at those hospitals together to provide an in-service, an overview of what Care Transitions did, how we can support physicians' patients. So we did that at the various partner hospitals. Whenever we were able to, we would ask the head of the hospitalist to be available, different physician groups that were associated with those hospitals, and then we even were able to talk and work with the medical director at some of the hospitals as well. This provided better information. It standardized, care transitions and what we were doing with the patients so that the physicians could hear it all from us and see the good work that we were doing with their patients.
That's excellent, Shelly. So many of our CCTP teams know that the hospital physicians can be some of the hardest to engage with Care Transitions programs. So it's great to see that you've had success with that and clearly demonstrated that enrollment is closely tied to engagement of those physicians. So I also want to ask about how you've been able to engage physicians outside of the hospital, specifically primary care physicians, because we know that engagement of PCPs is so closely tied to outcomes for Care Transitions participants. So can you tell me a little bit about what you've done with primary care physicians?
So one of the ways that we create a good partnership with our physicians is we have created a physician follow-up form. This actually came out of a conversation one of our coaches had with several physicians at her hospital. So physicians were asking her, is there some way that they could find out or be informed on what patients were participating in Care Transitions? So what we came up with was this form. So not only is it informing physicians that their patient is participating in a 30-day intervention with us, but it also highlights key areas that would need to be addressed at the first doctor's appointment since discharging from an acute care setting. There are boxes, as you can see, to check off and areas to enter text to further elaborate on any concerns the coach identified at the home visit. There's also an area showing the physician what referrals the coach made and what those referrals were for. So this PCP follow-up form is completed on a patient and faxed after each and every home visit is completed with a coach. The goal of doing this is to provide real-time feedback to physicians and make them aware of points to address prior to the patient appointment or at the appointment. So generally, physicians read the form, sign it, and fax it back to the coaches, letting them know, yes, we've seen this information. However, the exciting piece is we do have physicians that will also make comments or include resources and fax it back to the coaches. So some of the examples of this communication back and forth would be when a coach has put on this form, can you please write up some type of a letter for this renter who needs to go from the second floor to the first floor due to their physical limitations. And the physician will write this letter up and fax it back to us. Another example, we've had physicians where we've faxed in this letter to state, the patient is confused about their new diet, so the physician will actually fax us back dietary information to share with that patient. So we have found a lot of really good success from these letters, and our whole goal with this piece too is also, the hope is we're bringing a concern to the attention of the physician or the doctor's office, and that they're able to address it with them by the time they get to that first follow-up visit with them.
That makes a lot of sense, Shelley. Thanks for explaining that. It's something so easy and so simple for care transitions coaches to do, and yet clearly has had such a great impact on a number of your care transitions participants. And as a result of developing this tool, we've seen a lot of other teams develop similar tools that their care transitions coaches are able to use to bridge that gap between the hospital and primary care physicians. So thank you for sharing that and explaining that a little bit. And I just want to ask you one more question before we go, and I was wondering if you could talk a little bit about how your engagement of primary care physicians as well as your engagement of hospitalists has allowed for increased collaboration among all of your partners in your collaborative.
Sure. I would like to highlight one hospital in particular where we have, again, there has been in the past higher readmission rate at this hospital. But what has developed out of this hospital was a really strong relationship between our coach and a transitional care navigator that the hospital had hired. And this relationship really grew and morphed into developing a specific process for from the start, from when the patient is in the hospital. This transitional care navigator works with the patient and informs them that our coach will be working with them and kind of lets them know what to expect from our coach. So it's an easier process for that patient to say yes to that home visit. The great piece that has come from this is what we've identified is the coach goes out into the home, has the cell phone with her, and while they're doing the care transitions intervention, if there's any discrepancies that are identified at that home visit, such as something that the hospital or physician could assist with in correcting right away, that coach is able to call that transitional care navigator right away to address these concerns. So what has happened in the past is our coach will call her about a medication that there was a discrepancy on. A lot of times that transitional care navigator will either call the doctor's office right then and there and get it corrected, or she is able to seek some of those physicians out while they're still there at the hospital and get them to correct it right away. This also provides good communication. The coach is able to give feedback to this transitional care navigator who works very closely with the physicians in the hospital to address further needs or provide real-time feedback to those physicians either that day or the very next day, either in the hospital or by calling the doctor's office.
Thank you so much, Shelley, for sharing all of that and for showcasing your program and the success that you've seen as a result of these collaborations. And on our last slide is some contact information if you're interested in contacting Shelley about her program. So Shelley, thanks again for sharing with us today.
Thank you.